Hypoadrenalism, hypoadrenalism, acute adrenal insufficiency is an adrenal crisis, while chronic adrenal insufficiency or Addison disease is a progressive hypofunctioning of the adrenal cortex. These conditions are different severities of the same disorder. Causes of acute adrenal crisis include hemorrhage, surgery, hypertension, or trauma that rapidly destroys the gland. Sudden removal of chronic high-dose prednisone steroid. Loss of pituitary, rare but aldosterone is not under the control of ACTH. They are causes of adrenal crisis. Causes of Addison disease include autoimmune dysfunction of the gland, greater than 80% of cases, infection, tuberculosis, adrenoleukodystrophy, metastatic cancer to the adrenal gland. If ACTH level is low, the hypoadrenalism is from pituitary failure. If ACTH level is high, the adrenal insufficiency is the primary adrenal failure. Symptoms include weakness, fatigue, elevated mental status, nausea, vomiting, anorexia, hypotension, hyponatremia, and hyperkalemia, common in both acute and chronic presentations. Additionally, acute adrenal crisis, profound hypertension, high fever, confusion, and coma, Addison disease, hyperpigmentation over long periods of time. Over time, hypoadrenalism can lead to hyperglycemia, hyperkalemia, metabolic acidosis, hyponatremia, and HyPUN. Diagnostic testing include the concentropin stimulation test, more specific test of adrenal function. Concentropin is synthetic ACTH. Cortisol level is measured before and after the administration of concentropin. In a patient who is otherwise healthy, an elevated cortisol after administration of concentropin is a positive test that the patient has hypoadrenalism. Eosinophilia is common in hypoadrenalism. Tip: in acute adrenal crisis, treatment is more important than testing. Treatment is as follows. Replace steroids with hydrocortisone. Dexamethasone cannot be used because it has no mineralocorticoid activity. If there is still evidence of postural instability, administer fludrocortisone, a steroid hormone that is very high in mineralocorticoid or aldosterone-like effect. Use mineralocorticoid supplement in primary adrenal insufficiency if the patient is on oral steroids such as cortisone. Increase the dose of steroids in stress. Figure 2.5 Hypoadrenalism Diagnostic Algorithm. The patient will come with symptoms of weakness, hypertension, weight loss, and hyperpigmentation. We do concentropin stimulation test. Plasma cortisol before and after concentropin intramuscular IV. Cortisol fails to rise. High ACTH and aldosterone is low. Primary adrenal insufficiency. If low ACTH and aldosterone is high, secondary adrenal insufficiency, adrenal atrophy from pituitary insufficiency. A patient is brought to the ED after a car accident during which he sustained severe abnormal trauma. On hospital day 2, the patient becomes markedly hypertensive without evidence of bleeding. They have fever, a high eosinophil count, hyperkalemia, hyponatremia, and hyperglycemia. With more appropriate next step in management, be draw cortisol level and administer hydrocortisone. In a patient with suspected acute adrenal insufficiency, it is critical to administer hydrocortisone. It is more important than diagnosing the etiology. Hydrocortisone possesses sufficient mineralocorticoid activity to be life-saving. In addition, hydrocortisone will increase the BP because there is a permissive effect of glucagocorticoids, a vascular reactivity effect of retizolamide. BP will come up fast with steroids because norepinephrine will be more effective on constricting blood vessels. Primary hyperaldosteronism. Primary hyperaldosteronism is the autonomous overproduction of aldosterone despite high pressure with a low renin activity. About 80% of cases are caused by solitary adenoma and about 20% are caused by bilateral hyperplasia. It is really malignant. Who is most likely diagnosis? All forms of secondary hypertension are more likely in those whose onset is age less than 30 or age greater than 60, is not controlled by 3 high antihypertensive medications, has characteristic finding on the history, physical, or lab. High BP plus hyperkalema means primary hyperaldosteronism. In the case of primary hyperaldosteronism, there is a high BP in association with a low potassium. The low potassium is found on routine lab testing or because of symptoms of muscular weakness or diabetes insipidus from the hyperkalemia. Diagnostic testing includes ratio of plasma aldosterone to plasma renin, best initial test. An elevated plasma renin excludes primary hyperaldosteronism. Sample of the venous blood draining the adrenal most accurate test will confirm the presence of a unilateral adenoma or unilateral hyperplasia. It will show a high aldosterone level compared with a vena cava. CT scan of the adrenals done only after biochemical testing confirms the following: low potassium, high aldosterone despite a high salt diet, low plasma renin, aldosterone to plasma renin ratio greater than 20 ratio 1 and aldosterone greater than 15 is usually primary hyperaldosteronism. Metabolic alkalosis is common in hyperaldosteronism. Tip: never start with a scan in endocrinology. There are too many internal lesions of the adrenal. Treatment is as follows: laparoscopy for unilateral adenoma, epinephrine or spironolactone for bilateral hyperplasia of the page, and patients who can not have surgery. Spironolactone causes gynecomastia and decreases libido because it is an anti-androgenic. Amiloride is less effective. Pheochromocytoma. Pheochromocytoma is a malignant lesion of the adrenal medulla, autonomously or producing catecholamine despite a high BP. What is the most likely diagnosis? Pheochromocytoma is the answer when there is hypertension that is episodic in nature, headache, sweating, palpitations, tremor, and tachycardia. Orthostatic hypotension occurs between hypertension episodes. Diagnostic testing includes level of free methamphetamine in plasma. Best initial test. 24-hour urine collection for methamphetamine will confirm diagnosis, more sensitive and more accurate than urine mandelic acid (VMA). Direct measurements of epinephrine and norepinephrine. CT or MRI of the adrenal gland, done only after biochemical confirmation of pheochromocytoma. If CT or MRI is negative, MIPD scan or nuclear isotope scan can detect the location of pheochromocytoma near outside the adrenal gland. Treatment is penoxybenzamine, an alpha blocker. Best initial therapy. Surgical removal of the lesion is done laparoscopically. Pancreatic islet cell tumors. Pancreatic islet cell tumors are rare tumors of the pancreas that begin in neuroendocrine islet cells. Insulinoma. Insulinoma is diagnosed with the presence of hypoglycemia and elevated insulin. Most of these tumors are benign. Testing includes low glucose plus high C-peptide. Best initial test. 2 hours fasting with high C-peptide plus absence of ketosis. Most specific test. CT of abdomen, pancreas. Treatment is surgical removal done laparoscopically. Insulinoma. Glucagonoma. Glucagonoma is diagnosed with hyperglycemia and weight loss that is 100% of pancreatic origin. Most of these tumors are malignant. Glucagonoma is associated with necrolytic migratory erythema, a carcinogenic skin lesion. Treatment is octreotide, somatostatin, and surgical resection. Lipoma. Lipoma is characterized by excretory, high-volume watery diarrhea, hyperkalemia, and achlorhydria. Low osmotic gap for diarrhea, low iron B12. Testing includes high vasoactive intestinal peptide, VIP plus CT/MRI/endoscopic ultrasound showing a lesion in the pancreas. Somatostatin drugs, octreotide or lanreotide. Treatment is surgical resection. Molecular endocrine neoplasia, MEN syndrome. MEN1, MEN2A, MEN2B. MEN1 parathyroid, anterior pituitary and postgenital islet cells. MEN2A parathyroid, medullary thyroid, and pheochromocytoma. MEN2B mucosal neuroma, medullary thyroid, pheochromocytoma, and marfanoid. Diabetes mellitus. Diabetes mellitus is defined as persistent high fasting glucose levels greater than 125 mg per liter on at least 2 separate occasions. The most common symptoms are polyuria, polydipsia, and polyphagia. Decreased wound healing is common. Type 1 diabetes mellitus is insulin deficiency, onset typically in childhood, insulin dependent from an early age, not related to obesity. Type 2 diabetes mellitus is insulin resistance, onset typically in adulthood, likely related to obesity, or resistant to diabetic ketoacidosis, DKA than type 1. Antibodies to glutamic acid decarboxylase (GAD) are present in type 1 diabetes mellitus, seen in obese patients for diabetes. A diagnosis of diabetes is made with one of the following: 2. Fasting blood glucose greater than 125 mg per liter, single blood glucose greater than 200 mg per liter with the preceding symptom, increased glucose level on oral glucose tolerance testing. Hemoglobin A1C greater than 65.5% is a diagnostic criteria and is the best test to follow treatment response over several months. Treatment of diabetes mellitus focuses on goal HbA1c less than 7%. Diet, exercise, and weight loss control up to 25% of type 2 diabetes mellitus cases without the need for medications. Decreasing the amount of adipose tissue helps decrease insulin resistance. Exercising muscle does not need insulin. Oral hypoglycemic medication. Metformin, best initial drug therapy, works by blocking gluconeogenesis, does not cause weight gain, contraindicated in those with renal dysfunction because it can accumulate and cause metabolic acidosis.